Hello. So, I think last year you guys all had, I've clicked and nothing has changed, just so you know. Okay. This isn't quite, I'm clicking forwards, but it's not changing on the screen, just so you know. So last year you guys had a speaker here called Dr. Tony Iton from the California Endowment, and he was talking about the social determinants of health. Just so I have a sense of the bearing, how many of you were here last year and remember that? Oh, wow, okay, this is good. By the way, I've been in this part of the country twice, and it's been amazing weather. So I tell all my friends in London it's amazing here. So I don't believe that there was snow here last year. So, so yeah, I think this is sort of an amazing part of the world. So tell me when we're good. What am I? Are we good? Am I kicking off?
Try, and we'll...
By the magic. Oh, there we go. Everyone remember Tony from last year? All right, good. We're good, right? We're good.
Okay.
All right. So what Tony talks about is the social determinants of health. It's easy to sort of really to bring it down to this very simple diagram, which is that we increasingly now appreciate that when it comes to what makes us healthy or sick, 75% of it is about our behaviors, the social factors, and the environment. And about 20% is from healthcare, better access, better quality healthcare. And about 5% is in our genes. And this is a very sort of simple way in which I've just described it on stage. But where this comes from is a piece of research that looked at why do people die younger than we expect them to? And what would you invest in order to prevent that early death? And that was really what they found, was that 75% of the investment needed to be in that orange space, the behaviors, social factors, and the environment. So that's probably where Tony left you off last year, and I want to try to pick up from that. This idea of the social determinants of health is now so well understood that we can draw very neat triangles like this. So at the top, you're sick. And why are you sick? Because you've got changes in your body, physiological changes. So you may be obese, you've got high blood pressure, you've got too much sugar in your blood, you've got too much fat in your blood. All right? Why did that happen? Because of risk factors around how your behaviors, smoking, bad diet, not enough exercise, alcohol. And what are the things that underpin that? Economic insecurity, poor housing, poor education, unsafe areas, and poor access to food. Now, when you look at the bottom bucket down there, that appreciation of the fact that it all stems from down there, and really that 75% of the bottom two parts of that triangle, is what's really driving this idea that actually, given the economic insecurity, that's something to do with job opportunities in the area, housing, of course, housing department, poor education, schooling, unsafe areas, law enforcement being part of that, and poor access to food. Not quite sure which system does that, but the food system in general. There's this idea that actually we've got this, we're all working in the health system, but there are other systems that we need to work closely with, right? So that's coming up more and more. And what this answer seems to be that we need to integrate. We need to integrate service provision, health system, with a lot of the kind of service provision that exists in the community. And essentially what everyone's been working towards this idea of like finding ways to work together more effectively. Now there is some promise in this idea, and we're beginning to see evidence coming out. So one piece of evidence that came out from New York State looked at, it was a cost-benefit analysis of providing home services around asthma to certain communities. And actually what they found is that low-intensity home-based environmental interventions, that's just technical speak for the fact that they went in and probably sort of cleaned the house up a bit and like got rid of the things that was making them sick. Decreased the cost of healthcare utilization. More technobabble for they didn't come to the hospital as much. Okay, so that's good. There's some nice evidence there. Greater reductions are realized when services are targeted towards people with poorly controlled asthma. I love this bullet because isn't that obvious? That actually it would be better, this would work better for those people whose asthma isn't controlled. But there has to be a research paper that kind of has to make that point. And then this idea of public payers, so public payers, of course, Medicaid, should consider expanding coverage at least for patients with poorly controlled asthma who may be at risk for poor asthma control. So there's this idea that we can start using, or we should start considering to use Medicaid money to improve people's housing conditions. And that's what this evidence is beginning to say. And that evidence comes from the idea of the health system working more closely with the housing system. So that's interesting. I think this is just a couple of years old, this paper. And there's an interesting project in the Bronx called the Bronx Healthy Buildings Program. So that goes from 2 systems, health and housing, to 3 systems. So what they're doing in the Bronx is saying that there are some grants and tax breaks for weatherizing your building. So I didn't understand the word weatherizing when I first heard it, but it's about making your building more resilient to the weather. So basically not making it as cold, making your single pane windows, double pane windows, getting rid of the damp, getting rid of the mold, all that kind of stuff. And so they've realized that those grants exist. And what they've decided to do is they've also just worked out that if those buildings are more livable, people with asthma tend to fare better. Their houses are not as cold, it's not as damp, et cetera, et cetera. Not rocket science. And so what they've realized is they can go to landlords and help them get access to those grants, therefore building relationships with the landlords. And then whilst they know those landlords, go and try to build other services through those relationships. And so help those landlords get grants. Once in there, help them with pest management and something called green cleaning. And part of it is to show that if you can go, quote unquote, upstream, you can reduce healthcare costs and enable better health. So again, that's a nice, big, well-funded project in a very complex area in the Bronx, trying to work out how do we really bring, in this case, 3 systems together: energy, housing, and health. Now, there's one thing that I don't know if you all know this saying, but Sir Winston Churchill said that you can count on the Americans to do the right thing. This seems to be an example of the right thing once they've tried everything else. So who am I to counter Sir Winston, of course? Because actually this idea of integrating is getting a lot of noise in the US, but over in the UK, we've been doing it for a while, although quite interestingly, the UK hasn't been doing it uniformly. People talk about the UK health system. There is no UK health system. There are 4 health systems across the 4 nations of the United Kingdom. And actually, Northern Ireland, Scotland, and Wales have had versions and attempts at integrated care for way longer than England. And England very recently is starting to talk about integrating. And so they've decided they would need to go and learn from the other 3 nations of the UK. And so this paper is actually from the main sort of policy think tank in the UK called the King's Fund. And what they did was they went to the other 3 nations in the UK to go and work out, okay, how's integration going? And when I say integration, what they're really talking about is integrating health and social services, and so essentially from the kind of hospital sector into the kind of community sector. And they wanted to go and try to work out, how's it going, and what are the lessons for England? And Northern Ireland's been trying this since 1973. Scotland started in 2004. Wales followed suit in 2009. And one of the things that in trying to understand that, was they realized there are very few well-designed studies to evaluate what this takes. And so what they try to do is, so those are prospective, are there prospective studies to understand what makes integration work? No. So there isn't a great evidence base for it. So instead they said, well, why don't we look at routinely collected data to work out, is Scotland performing better than Northern Ireland, England, whatever, how's it going? And actually they found that was very difficult because how the 4 different health systems collect their data is also different. So actually it's very hard to do comparison across the 4 nations of the UK. Now, despite those methodological concerns, they did go in and look at those. And then in Northern Ireland, what they found was there's little systematic evidence that integrated health and social care has demonstrated measurable improvements for the population. That's pretty depressing. Started in 1973. Now, let's not forget the context. We're talking about Northern Ireland, right? So they had, this is euphemistic techno-babble, lengthy period of policy inactivity, both before and after the creation of the Northern Ireland Assembly, I think otherwise known as the IRA. So we had a slight kind of problem with sort of some domestic terrorism that went on for quite a while until the Good Friday Agreement. And that's a lovely kind of techno-babble to explain that. But there wasn't a huge amount of policy going on while they were dealing with what we call the Troubles. But the other thing that was going on is that social care was taken out of the local authority being kind of local government, not because there was a belief that social care had to work closer with healthcare, but because there was a belief that local government wasn't working very well. So it was a kind of a remediation step of like, let's take it off them because the people are suffering. So that was a very different motivation to saying, how do we integrate health and social care? So it wasn't the perfect kind of environment in order to see whether integration worked. And that was really what they found from what they've learned from trying to integrate in Northern Ireland is we haven't really learned anything because of the environment in which that was happening, despite it apparently going on since 1973. Scotland has made better progress. And that was really 4 reasons why that is. The organizational stability. So in England, what happens is because we have a tax-funded system, every government comes in with some great new idea about what they're going to do with the National Health Service. And so every 5 years, every new government, there's a sort of reorganization. They haven't had that in Scotland. They've had a certain amount of organizational stability, and where there's been political consensus around the idea of integrating health and social care. So they've had a good long run at it, and the ministers have all been behind it. And there have been policies aligned with the idea of integrating. So those 4 factors mean that there's actually a much more kind of fertile environment for integrating health and social care. And in fact, they've come up with this kind of scorecard of 16 national outcomes and 50 indicators and targets, which every locality uses. And they've even actually wrapped that up into what they call a single outcomes agreement between the government and the community planning partnerships. So there seems to be good sort of overarching policy environment and where this work is doing, and a clear understanding of what every locality is trying to get to, and it's the same understanding so you can do analysis across different localities. That seems very good. And they've been going at this since 2004. But arrangements for joint working between the National Health Service and local authorities centered on community health partnerships are not working. And this is what they found. So even though the policy environment is very good, even though they all know what they're measuring towards, even though they've all signed up to something called the Single Outcomes Agreement, they're still not working. And they haven't really got to the bottom of why. And they found that the health boards, these are the kind of local organizations that have to think about the health of the community, have struggled to bring about any significant shift in resources from the hospital to the community. I saw a nod and a smile in the room at that point. This chap there is nodding, and a thumbs up. There we go. And I think this is something that this is going to be a theme that is going to show up over again and again. There is a challenge here. Wales, they're very much in the early stages, started 2009. That is not long when we're talking about changing entire systems. But it's been difficult, they've also found, it has been difficult to shift resources with local health boards from hospitals to the community. Again, local health boards, the organization is thinking about the health and wellness of that community. Difficult to shift those resources from hospitals to the community, let alone health to social care. So there's this kind of resources issue. The resources are not flowing to where the need is. And in Wales, they found probably sort of 3 barriers: a lack of alignment between those boards and the local authorities, different funding streams, pockets of money there, pockets of money there. Are they aligned? Are they really getting all behind the same thing? And long-standing professional loyalties. Do you guys use the term NIMBY? N-I-M-B-Y? A nod and a shake. Not in my backyard, right? It's the acronym for not in my backyard. This is sort of wonderful think tank technobabble. This long-standing professional loyalties. It's just basically people don't want to change. Yeah, we agree this is the thing to happen, but we don't want this to happen in our backyard. And they actually have a really strong political commitment to this change as well, 9 years in. And they're still not seeing the changes that they think could happen. Maybe one of the problems is they haven't quite got to that single outcomes framework. That was a hypothesis in the paper, but we'll see. So what did this think tank say to England? So what did it learn from the other 3 nations of the UK, and what did it want to say to England? There are formidable challenges in realizing the benefits of integrated structures. In fact, the paper says the possible benefits, because they're pretty theoretical at this point. Hard to exaggerate the power of hospitals. I'm getting more. Oh, I had a little grunt as well there as well. Hard to exaggerate the power of hospitals. It's hard not to say that enough time. I mean, that is an incredibly important part of this challenge. Structural change, like reorganizing a system and writing policy papers, will do little unless politicians are prepared to manage unpopularity. One of the key things that health systems in high-income countries have been dealing with for a while now is about saying, we don't need the hospital, we need the services in the community. And we can actually have fewer high specialist centers because we have better transport, we have better ambulatory care in our ambulances, all that kind of stuff. We have better care in our ambulances that can get people to fewer specialist centers. So what does that mean? It often means closing local hospitals. Usually one of the most politically unpalatable things that a politician has to do. And there has not been that kind of political leadership. And here's a thorny one. The NHS in England, the National Health Service in England, outperforms the National Health Service in the 3 other nations in some of those measures. So there's this kind of mantra we've got to integrate, but actually, do we have to integrate in everything? It's not really clear where it will be beneficial and where it won't be beneficial. And structural integration is only one factor among many in facilitating the development of integrated care, because there needs to be a willingness to challenge professional, cultural, and behavioral barriers to integrated care. This thing of it's hard to exaggerate the power of hospitals, that actually, and this last bullet around the willingness to challenge professional, cultural, and behavioral barriers. It seems to me that everywhere I've gone, that's actually the biggest problem, more than anything else, because everywhere I go, especially when I'm in the community sector in public health, there's a very clear understanding that this is the thing that needs to happen, and yet it doesn't happen. And in fact, my entire career was I was thrown a curveball many years ago by seeing this slide. This is from your Congressional Budget Office. It was published in 2007, and around that time, everyone was talking about aging, the demographic bomb. It's going to destroy our healthcare system. We're already at whatever percent of GDP on healthcare spend you were at the time, and aging was the big problem. And I saw this from your Congressional Budget Office. Now, down the side, what you're seeing is percentage of GDP going on essentially on Medicaid. And it was where it was in 2007. And what they illustrated by plotting forward 75 years is that actually the effect of aging was tiny on cost. But the big line going upwards, the big light blue line going upwards, is actually just the effect of excess cost. Again, technobabble for healthcare is getting more expensive because healthcare has decided to be more expensive. It's a growth industry. And clearly they interact. If the unit delivery of care is more expensive and you have an elderly population that has multiple chronic conditions that need more care, there is going to be a process of interaction. So that's the kind of mid-blue level in the middle. But it's important to really hold on to this thought. Healthcare is more expensive because healthcare is deciding to be more expensive. You talk about the power of hospitals, you talk about professionals not wanting to change. Why would you change if you're in one of the biggest growth industries in the country? 18% of your country's GDP, $2.7 trillion and growing. Why would you change? Where is your motivation to change? So we're going to talk about integration. That's the key thing you're going to need to get on top of. Now, I present this slide all the time because this has personal relevance to me. I was a clinical publisher. I was enjoying my career, and I suddenly saw this, and I thought, this is mental. This is crazy. What am I part of? I used to work in clinical improvement, talking about improving the flow of patients through the healthcare systems, and I just realized there are some deeply fundamental issues that need to be talked about here. There's no point in me just maximizing the flow of patients through hospitals. There are bigger issues at play. But people say to me, come on, that was 2007. Things have changed in the last 11 years. Yeah, they have. Here's an example. Last November, 4 months ago, the American College of Cardiology published in JACC, I think the Journal of American, I can't read that, American College of Cardiology, JACC. They published new guidelines for hypertension, high blood pressure. And what they realized was, so if you have high blood pressure, forgive me if you have high blood pressure and this is a shock to you, but if you have high blood pressure, it is the gateway to everything else that's going to go wrong. It's going to give you your angina, it's going to give you your heart attack, it's going to give you your stroke, it's going to give you a chronic kidney disease, it's going to worsen your diabetes. High blood pressure, once you get it diagnosed, you need to treat it massively aggressively. It is at the root of everything else that's going to go wrong. And so not unsurprisingly, the physicians at the American College of Cardiology say every year they come up with their guidelines and they look at all the long-term data around high blood pressure, and they say, at what point do we need to treat high blood pressure in order to reduce those long-term impacts? And every year, pretty much without fail, the pressure at which you need to be treated has gone down. And that, you could say, is great, because we have long-term data that shows that we didn't treat these people and they had a much higher risk of myocardial infarct, of stroke. Great. Sounds great, right? But this one paper, published in November 2017, if you apply its classification to the American population of what is now hypertension, what is now high blood pressure, 30 million more Americans became hypertensive overnight with that publication. The day before, they were not hypertensive. The day that got published, they were hypertensive. And I used to be part of a system where you take those guidelines and you apply them into clinical practice through electronic medical record systems. So the speed with which that gets published and then flows through the healthcare system is pretty much unprecedented right now. And that is a 30 million patient growth overnight from a paper. And that growth, the money that is going to go on, the interventions, the drugs, all of that kind of stuff, that money is coming from the same purse that community health needs. So this is the battle. This is a battle of power. And that one paper, and by the way, when it got published, no one seemed to react too strongly to it. New England Journal of Medicine kind of wrote a thing about, oh, it's really good, we're learning more about hypertension. But the amount of money that single paper has created a market for overnight with a snap of the fingers is extraordinary power. Extraordinary. And I say this as a physician, I say this about my own gang, is that this is what we're unbelievably good at. And it is the thing that we're going to have to work on. And the combination of those two last slides, the graphs going upwards and the fact that that's been going on. And by the way, I just chose one condition. There are over 200 guidelines producing organizations churning out guidelines left, right, and center saying, but the clinical evidence says you have to do X, Y, and Z. That is going on in every clinical specialty going. It just so happens that hypertension, for me, is a really important one because of its clinical importance. So a few years ago, when I was working with TED, putting on their TED Med show, it was kind of interesting. I was looking at the innovations, and I was thinking to myself, this is all playing in the margins. And that actually, what we're failing to understand is that in high-income countries, all of our societies are getting sicker, and healthcare is radically unsustainable. Okay, this is America. You have to do everything bigger and better, right? 18% of GDP, $2.7 trillion. You're sort of contractually obliged to go for the big thing. Everything gets supersized over here, right? But England's at 9.6%, completely unsustainable healthcare system. France, 12%. Germany, 12%. Everyone is worried about this. And in the face of our ability to write guidelines that medicalizes 30 million people in your country overnight, what we're looking at is trying to find a different way of looking at the problem. What if we ask the community what's right or wrong? What is community-defined health? What matters to those people? And I say that partly because I grew up in a low-income community, a low-income immigrant community. And pretty much most of the stuff I learned in medical school, especially around kind of lifestyle-related stuff, I used to sit in the lectures and think, no one from where I'm from is going to listen to that. I'm not going to do any of that. So you just sit there and think, what are they teaching these white people in this room? This is not what happens in my community. And my community is one of the sickest in a small city called Leicester. So I wanted to go and understand what is community-defined health. And what was really important to me was find people who would talk about a community's definition of health. And, we tend to use words like wellness and well-being, and these are all, they're nice kind of broad terms, but I wanted to hear what those communities were actually saying mattered. And they would say things like economic security. We know them as the social determinants of health, but you have to hear it in the community's word. What matters to you? Knowing my neighbors. People say knowing my neighbors. What matters to your health? Knowing my neighbors. Well, they don't teach that at medical school. I also was really interested in people doing the work, not people theorizing the work. There are about 28,000 biomedical journals of people just talking about health. But I'm like, that's great, you wrote a nice paper, but let's just talk about the plurality of what's going on in communities. Let's actually hear them and what they're saying, their work, not the theory. And I also wanted to hear about the struggles, because I don't have this data today, but if you look at things like rates of diabetes, rates of chronic kidney disease, there is basically an upward swing for about 40 years. There have been moments where they level off and then they pick up again. And this is pretty much happening in most OECD countries. Some started later. I mean, Australia's upward curve is way more steep than yours right now. But they started later and all that kind of stuff. So it's happening everywhere. And yet, whenever you go out there and look at innovation, it's always glossy. It's always cool, interesting. This is the thing I did, yay. But if we've got graphs that are going out of control for 40 years, surely the dominant narrative is total failure and struggle. So I wanted to find the people who were willing to talk about failure and struggle, because it seemed to me that they were more important than the people paying really expensive PR agencies to talk about their amazing community-based diabetes prevention program that they then want to call evidence-based and see get rolled out. So I ended up going out to find those people. We ended up becoming a meeting. I never wanted to create a meeting, but we ended up becoming a meeting because the people I met wanted to meet other people I met. And so we had this meeting in my friend's boardroom in New York. We gave ourselves a name, the Creating Health Collaborative. We even gave ourselves a logo. We called ourselves Exploring Health Beyond Healthcare. And so we've been doing that, and we've had about 50 people come to that meeting in New York. We never have more than 20, because when the room's too big, people don't really share as much as they would. We spend a lot of time trying to break down the kind of inhibitions between people. And what I was doing was trying to find out, what are the patterns? What does it mean to work in these difficult social environments where health is out of control, where people are dying younger than they should be? What does it actually mean to work in those environments? And what I ended up doing was finding 12 principles. Now, I'm not today going to go through it. Describing the 12 principles and how I came about them is pretty much a kind of a whole hour's lecture. But that was ultimately what we published last year. This is actually now last year's report, but I did bring actually the last 2 copies with me, and I'm happy for them to stay here with people who are interested to understand how we got to this. But the principles, what we had realized, we're really talking about, I thought what I was doing was going to go out there and find a model for community health. And those of you who work in communities will all know that was dumb, because no 2 communities are the same, right? But I'm a physician, so it's a synonym for being dumb about communities, right? That was it. Honestly, I started 5 years ago thinking I was going to go and find this model, because in my world, there's a model, and you apply the model, and you do comparative effectiveness studies. That's dumb. That's intellectually broken. And I had good people in communities just kick me really hard and just tell me, go away, you're a moron. And I ended up coming up with this understanding that actually the recurrent patterns that I saw were what I call the 12 principles. And I thought to myself, what is this? And I was trying to make sense of it. I actually had 11. It became 12 last year, but I had 11. And I was really struggling to work out, what am I seeing? And someone said, go and talk to Professor Len Syme. So Professor Len Syme he's 85. He retired about 20 years ago, but nobody can actually get him out of Berkeley. He's still there, still teaching. And he's considered to be essentially the father of what we now call the social determinants of health. He's probably the very first ever person who could have been described as a social epidemiologist. And that orange thing, looking at what's the 75% of why people die earlier than they should, that was very much kind of Len Syme's work. And so someone said to me, you've got all these questions, go and talk to Len Syme. Len's one of these people who answers every question with a question and leaves you feeling even more puzzled than when you walked in. I'd hate to be in one of his classes, but I did actually learn from him that risk factors account for less than 50% of death and disease. Now, no one ever talks about that, because everywhere you get those really nice triangles of like, we've got to do housing, economic security, these are social determinants of health, these are things we've got to do. That whole bottom of that triangle only explains 50% of death and disease. It's not the whole picture. And in fact, if you're doing housing, which is only part of it, you're playing in the margins. And in fact, if you're doing asthma in housing, you're playing in a margin of the margins. So what are we really doing here? And Len said to me, this is great, you've got this whole thing, but the other 50% of why people are dying and sick is because they have no sense of control in their lives. They're lost. They're adrift. And that sense of control comes from something called agency, the ability to make purposeful choices. And Len wrote a book chapter about this in 1990, and what he wrote in that book chapter was, he's a hilarious chap, unbelievably self-effacing, and he wrote in his book chapter about how he's so daft, and that he spent years trying to prove that burnt toast gives you cancer and blue suits give you, melanomas. And he's been one of those guys who's collecting massive data sets and finding green bags are really bad for your risks of stroke. They're on the news every day, right? But even if that stuff is really clear in correlatory studies, it doesn't matter how much of that we've learned, we're still playing in the margins of that 50%. And Len said that actually what seems to matter is whether people have a sense of control, whether they have agency, the ability as individuals or collectively to affect their circumstances. And that isn't agency to choose an apple over a chocolate bar. We're not just want agency so that people can make a purposeful choice about, I'm going to go to the gym, not to the bar. Actually, agency just matters about who you are in your life. If you have a sense of hope, if you have a sense of where your life is going. Agency just matters. Now, I didn't get any of this, but what we realized was that agency could be fostered through, do you like my grammatical error there, just to see who's awake? An inclusive, participatory, and responsive process. I normally make fun of the Americans' use of English and how you butcher our language, but I kind of lost the ability to do that now. So, by the way, I'm loving seeing law enforcement continually here. It's making me more polite than I usually am. So there's the report. And the thing for me is that having been in the TED environment, this whole kind of conversation about innovation has just become entertainment. You can go to TED and learn about TEDMed, about innovation, and you can go to Medicine X, and that's the version of innovation, and you can go to exponential medicine, and that's the one from the Google University, and that's a form of innovation. And I sort of find that, I think that we've kind of got ourselves into kind of a problem area. So what I was really trying to do is say, how do you take that thinking and apply that? So we took those 12 principles, which again, you can read about separately, but it's all about an inclusive, it's not rocket science, and we turned it into a tool. And that tool is a kind of a mechanism to help health systems or collaborations or collective impact, whatever the structure you're trying to put in place, can start asking themselves about how you're working. Because how you work can either foster agency or dampen agency. And so you can make really intentional choices. But if you're going to foster the agency of a community, their ability to make purposeful choices, you're ultimately asking them to step into their power. And that's pretty tough when we're talking about how healthcare systems generally don't give up that power. In fact, they write papers that give them power over 30 million more patients on a single paper. So having sort of wrote that, we published that in March 2017, and then we held a symposium May 2017. First time we did a national meeting, 150 people, all descended on Oakland, California. And it was fun, and what we tried to do was our aims were to say, what does it mean to create mutually accountable partnerships between institutions and communities? How do we think of new ways of thinking about understanding and measuring value? So if you go into community and say, what matters to you, they may not say diabetes, they'll say something else, but they value it. You value diabetes because you're from the healthcare system, maybe not you guys, but someone from the healthcare system say, we care about diabetes. How do we start understanding that different way of understanding those different types of value, and how do we have that conversation at the table, that those two types of value have parity in the discussion? And how do you use capital? That's not just money. That could be reputation, that could be momentum, whatever, but how do you use the capital to invest, to design and explore new ways of working? And that explore bit is really important because we don't really know what it means to work in the ways that we're talking about right now. So how do we get there? Now, the symposium, we thought we were smart. We were like, we wrote a report. I had it designed. Looks really nice. So I'm going to hold a national conference, and I'm going to get funders to fund it, and this is great. And actually, it turns out that we made so many errors along the way that we ended up commissioning a series of articles that we're currently serializing on our blog at the moment. And they will be going into our 2018 report. And one of the things one of the kind of mistakes we made is we kind of assumed, again, I'm a physician, synonym for someone who's not very smart. I assumed that what we were doing was helping the community-based organizations understand more about health. And at the end, someone came up and said, so who was doing the learning here? Because the physicians don't seem to understand us. So who's actually doing the learning and who's doing the teaching? And how do you actually create an environment where there is parity in knowledge? And therefore, the direction of knowledge transfer, learning and teaching, is both. In fact, it's not even two directions, it's in multiple directions. But how do you create that parity in knowledge and teaching? Discussing health, this was totally through me, actually. And it shouldn't have done. But I didn't really get this. But discussing health is essentially discussing systems of oppression. Because there are oppressed communities, there are excluded communities in all of our countries. All high-income countries have a version of this. You guys have your own flavor of it. And health is one of the systems that has oppressed. And so if you actually want to go and have a conversation about, hey, your community's sick, what are we going to do about it? We can't really start at their diabetes. We actually have to start at that kind of historical amount of oppression that has been manifest by these systems. Systems are designed intentionally. And so people who are excluded, they are intentional exclusions. There are sort of really big examples of that. Things like really awful things like the Tuskegee experiments, trying to work out, what happens with tertiary syphilis. Oh, let's give this sort of low-income black communities not enough care to see what tertiary syphilis looks like. And I've actually worked with someone who actually knew someone who was actually in the cohort in the Tuskegee experiment. There are kind of the big headline versions of that. And they're still alive, and those people who were in those experiments still can share those stories. It's not that long ago. But that's a big, glamorous, sort of awful version of what's going on. And actually, these systems of oppression are happening all the time. And then the other thing that I hadn't realized was that if you want to discuss oppression, you've got to realize that the room's going to get triggered. So we had in the symposium, we had a guy on stage share what it was like, growing what he was like, and actually we spent a huge amount of time prepping him. He was from a low-income community. He'd been addicted to stuff since he was 7. He'd been homeless multiple times in his life. He's now in his 60s, getting it together, runs a non-profit in Massachusetts, and is trying to get other people to kind of understand the journey he's been on. And we spent a long time with him to explain what it means to go to a symposium, what it means to be on stage, et cetera, stuff he's never done before. He's never been a kind of keynote person before. All new to him. We spent ages prepping him. We were very proud of ourselves. And then the feedback was people in the room felt traumatized. Because actually his experience triggered experiences for people in the room, because we worked really hard to get people from oppressed communities in the room, and suddenly they were there and just feeling really difficult about this conversation that needed to happen. So if you're going to talk about collaboration, you have to or integration, or whatever term you want to use for this work, you do have to sort of realize that those are the things that are actually going to surface, and you need to create the infrastructure to enable that. The space for that. I don't know if you want to call it generative listening. I don't know if you will have to go and learn about U theory. There are lots of sort of different methods to how you do this kind of stuff. But it isn't as simple as holding a meeting with a shared agenda and getting people around the room and having a conversation. Because there's a lot going on in that conversation. And we have to be able to learn and iterate in this work. So one of the most common things I heard from the people who came to those New York meetings and their work became the 12 principles, and those 12 principles are in the report. The thing that I heard with unerring frequency was that the best project said, it took us 2 years to get going. And when I first heard them say that, I was like, wow, what are you doing for 2 years? Like, what's going on, right? Again, physician, synonym for. So I was like, what is wrong with these people? And eventually they just they sort of realized that it took 2 years for people to trust them, for the conversation to start, for the real conversation to start, for the real problems to surface. And that isn't just a matter of kind of waiting around for 2 years. You have to work intentionally, and you're usually making mistakes as you go, but you have to be open to doing that, and then going back and saying sorry. Because what's happening is a lot of these communities have been let down repeatedly. In fact, what they talk about is how people turn up with clipboards, and say, I'm going to use some crass terms here, but they're like, hey, fat, poor person, let's hear about your life. Tick, tick, tick. Then they go away and they write a paper, they get published, and they get a promotion, and then they go and get tenure in their university, whereas the person who I won't call what I just called again is sitting there going, but nothing changed for me. You got a promotion. What happened to me? In fact, my favorite line on this is like, when you do your surveys, you get a promotion and my washing doesn't get done. That's all it is. We go and use people for their time. And so we have to build trust with those communities that have been excluded for so long. Now, by the way, I'm saying all this. This is lessons learned from our symposium, and I thought I'd learn all these in trying to get that report down. And so it's so hard to do this. Like, when you actually try to go from observing what's going on to then being proactive about how to do this work, it's very easy to get it wrong. And the other thing we got wrong was we kept just using the word community. Now, I know here in your Snohomish County, there we go. I thought I'd say it once from stage. That's it, that's done. So I know here in Snohomish County you have, that's twice. You have very different communities. And people use the term community all the time. Community, 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 community health, community. What does it mean? Who are these communities? And actually, one person said in the feedback to the symposium was that, because we had people from the health system, we had people from the community sector, and we had residents as well, and they felt very othered by that. They felt genericized. They felt dismissed about the idea that they were from the community. And partly because they looked at other people who are from the community, and they didn't feel like they had much in common, apart from the system just kept not understanding who they were. That was the only thing they had in common. But they were just from very, very different settings. And then the other thing that became really clear is that this isn't community benefits. So, the ACA, you have the whole community benefits mandate for a non-profit hospital, et cetera, or it's about corporate social responsibility. It can't be about those little margins of money. It's about the very fundamentals of how healthcare is working, because a tiny bit of community benefits money to do a little bit of community engagement in order to continue to get your non-profit status to run that big lucrative hospital is missing the point. Is that there is a fundamental mismatch between systems and the communities that they say they support. And I say this again, those lessons are learned after 5 years of doing this work and putting on my first national conference here in the US, and just realizing, wow, I thought I really thought it through and delivered an event and thought about what does it mean to do cross-site working, et cetera, but we made so many errors. And these are I just cherry-picked a few from the 11-part series that we've published 9, we only have 2 left, that we're publishing on our blog right now, reflecting on our own symposium. Now, all of those are going into our new report. This is pretty much just a screenshot of something that is right now being printed in London. And we've changed the name of our work. We said fostering agency to improve health. We still think that matters. But actually, the fundamental thing that needs to happen is to bring purpose to community engagement and to provide a framework to reconceive healthcare's relationships with communities. That's what actually needs to happen. If you reconceive that relationship, part of what you're doing is actually fostering agency in the community, but there needs to be a kind of fundamental shift in that. And what we also realized since publishing last year's report is that everything we've been saying, the community-based sector and public health have known this. And the only people who don't get this is the healthcare system. And as what people often say to me is the only reason why anyone listens to you or books you for a keynote or which hospital CEO talks to me, I know you know the answer. What's the only reason why they take my meeting? You're all too polite. Someone said it over there. It's because I'm a doctor. That's it. And I'm saying stuff that is about 30, 40 years old. I think the accent helps as well. That's what they tell me. So it's all about a framework for reconceiving the relationship with communities and bringing strategic purpose. We need to kind of bring strategic purpose back to hospitals, because there's this big shift that's going on, and hospitals have not woken up to it. There's a rhetoric around it, endless rhetoric around it, but I'm not seeing a shift in ways of working. And that shift is this. I can't find a good graphic to describe this, but essentially this is looking at the burden of disease. I think it's 2004 to 2020 or 2030. And the thing to do is if we just read down the middle list. So lower respiratory disorders, next to it, you see it's got a sort of very steep downward thing. So they used to be the big killer, and now it's swooshing downwards. Diarrheal diseases, this is global data. I know you don't have a huge amount of diarrheal disease in this country, but diarrheal disease, lots of people die. A child dies every 5 seconds from diarrhea or something? There's some crazy stat. But we're going to see that probably plummet by 2030. Unipolar depressive disorders, so mania or depression, that's going up. Ischemic heart disease, going up. HIV/AIDS, going down. Cerebral vascular, stroke, going upwards. Prematurity, low birth weight, going downwards, et cetera, et cetera. The pattern there is that infectious diseases in general are on the decline, and diseases that relate to life circumstances are on the up. Now, everyone knows that. That is like the thing that everyone talks about. But there is a fundamental different system required for the information on the right to the information on the left. And that transition has barely begun. And it seems to me that that's where healthcare is struggling, because it got really good at dealing with the infectious diseases on the left. They provided, drugs, quarantine, all of that kind of stuff. When disease burden was infections and trauma, it was pretty much a lot easier to deal with. And that shift hasn't started. And systems everywhere are struggling with the shift. And one of my favorite systems innovator is this guy, Julian Corner from England. I would never say that to him, but that's him looking, I don't know what he's doing there actually. He looks a bit shifty, actually, now I look at that photograph again. He's not usually very shifty, he's very much an English gent, but on this occasion he looks shifty. He looks like he's just come out of court as well, so perhaps I need to have a word with Julian about his Google image search. But anyway, that aside, apart from Julian's criminal past, it's not your jurisdiction, people, you settle down. So he commissioned a piece of research called Bringing Everything I Am into One Place. What Julian's foundation does is look at people who have severe and multiple forms of disadvantage in England. And usually that means people with behavioral health issues who are homeless. That's the sort of the classic cohort that he works with. And their foundation is specifically designed around that because they say that if you can actually move the dial with those people, it will echo through systems change for all other things. And actually, one of the things that, in their research, they looked at kids that needed high-end services. So the big circle are the total population of kids. And what they actually found is that the blue circle, the big blue circle within the circle, as it were, are the ones that had multiple needs. And the green circle were the ones that actually got the services. And there's only a tiny overlap in red. And that's what they found in their research. And they said, what's going on here? How is it possible that we have all these services? We're talking about England, so there's huge safety net here. How is it that we've got this disconnect going on? And they went and they interviewed and they scratched underneath it over and over again. And what they realized was that the system thinks it's doing this, slightly small font, but black circle, problem-defined group, so the kids with the needs. You do a risk assessment. If they are at risk or if they require an intervention, you provide that intervention and then you get an outcome. That's what the system thinks it's doing. Actually, what the system's doing is this. They start with their tool, the risk assessment. They apply the risk assessment and they do the intervention and they get an outcome, and that way they define the group. That's not the same as working out who needs the services, because the systems have been designed around the tools, as opposed to designed around the need. The risk assessment tool coming first in the lower diagram. And that's where they've got to. And so they're a foundation that looks at people with severe and multiple forms of disadvantage, but they ultimately are in the game of systems change and trying to work out how do they get systems to move to that bottom diagram, because they're currently doing the top and quite frankly failing awfully. So to conclude, yes, we need to do this. Yeah, we know we need to do this. There's a feeling, the evidence isn't clear, but still, our experience of having to work across different systems that are siloed tell us that we need to do this, even if we haven't got great evidence that it's working, at least from the UK evidence that I've shown you. Quick, small wins are possible. Yeah, great. Asthma and housing. We're seeing papers saying that all around. But remember that that's a margin within a margin. So if you need to start there, great. But don't ever tell yourself it's anything more than a margin within a margin. Shifting resources is about power dynamics. Literally just say that back in your heads over and over again. We are in a power play. And in that power play, communities need a voice. They need to be able to express their agency, because how else are we going to make things change? And it has to change because diseases has changed. We die from life circumstance-related conditions more so than we die from infections and trauma. And as I title this talk, It Ain't Easy, this is not remotely easy stuff. But we do have to persevere, because what we know is that we've got about 40 years of failure in this. So we have to push ahead into the fog and try to work out what that new way of working is. Thanks for listening.